2nd of August to 30th August. That big, and obviously the weekends between the so first 2 weeks of August.
So I'm gonna actually ask Charlie. Charlie, you can hear me, right?
Yes.
Fantastic. Then can you see the screen and slides?
Yes.
Fantastic. So first of all, I'd like to apologize on behalf of Victoria Kane. Unfortunately, she's not well this morning. So she has kind of asked me to try and see if I can talk on a subject which, while it's close to my heart, obviously I'm going to say that I am with other experts amongst the participants. So at the moment, we've got some streams of participation from our network. We've obviously got some participants who are watching this over YouTube. We've clearly got colleagues who are actually watching this and interacting with me live. I think what I'm going to do is I'm going to make a start and I'm going to talk a little bit about the religious, spiritual, and cultural considerations, but specifically by talking about management at limits of viability. And what we're going to do is we're a small group. So as we admit people, we're going to have a little bit of a case-based discussion where it would be very interesting to kind of see what your views are. I'm going to start by saying that if we look at the burden of death at limits of viability, I mean, this is very contemporary data, and this is data which basically stretches back 2 decades. So, I mean, if you look at survival for babies at 22 and 23 weeks in a cohort of the NICHD, which is the United States, that's 27 participating centers, very similar to how we contribute data to the Neonatal National Audit Project. You'll find that survival for babies at 22 weeks was 7%. Survival for 23 weeks was 28%. Now, clearly, during this period, if you looked at the limits of viability, there was clearly quite a lot of centers, even in the States, who practiced the concept of comfort care, speaking to the parents, giving them the information choice. I think virtually everybody at 22 weeks, including the States, people were tending not to resuscitate babies at 22 weeks during that period. And what you can see is that over the past 2 decades, as we've headed towards, this last 5 years, the actual rates at which babies at 22 weeks are surviving is still the same. So it's not increased significantly, marginally. And but if you look at resuscitation for babies at 23 weeks and 24 weeks, there's been a significant increase in that we're resuscitating babies and they are surviving to discharge. And these are survival figures to discharge for babies who were admitted to the neonatal unit, so not live births. But you can see that, that's a pretty decent survival to discharge. 50% of babies at 23 weeks from 2013 to 2015. But if you look at survival at 24 weeks, it's about 70%. I mean, if I give you figures, 3-year averages for our unit at the moment, for 23 weekers, survival is in the range of about 70 to 80%. And I mean, for 24 weekers, survival is about 86%. At 25 weeks, 90% of our babies survive. So what I'm trying to emphasize by this slide is the fact that there is a huge burden of death, especially at lower gestations. And clearly, from our perspective, we now have new guidance. We have the British Association of Perinatal Medicine guidance, which talks about discussions around resuscitation at 22 weeks, shared care decision-making, parental choice, and risk assessing and trying to quantify how high the risk is for the baby dying, but also what neurodevelopmental outcomes this baby might have at a later stage. Speaking to the parents about this, discussing and having and giving them options. And in a sense, once you've risk stratified, if you fall into a very, very severe category, then palliative care is definitely an option that needs to be discussed with the parents. The key thing from our perspective is, what do we do and how do we take the cultural aspect into account? Now, I think before answering and talking about that particular question, I want to talk about where these babies die. And this is a slide which basically compares data from the EPIPAID study in France with the EPICURE-2 data with the Express data in Sweden. And what you'll find is that there are 3 approaches that have been followed here. So if you look at the EPIPAID data, And this is a study from 2011, which looks at survival, resuscitation, and active treatment for babies who were resuscitated between 22 and 25 weeks in France. What you'll find is that a very small number of babies in France at 22, even 23 weeks in 2011 were actually being actively treated. And a majority of babies, so a very high incidence of stillbirths, but for the babies who obviously were managed, the majority of them died in the delivery room, and comfort care was probably the norm. Very few babies actively resuscitated. Once you come to 24 weeks of gestation, you find that a significantly higher proportion of babies are starting to be actively managed, and actually survival of those babies is about 50%. I think more or less, I would say that once you come to 25 weeks of gestation in France at that particular time, a lot more babies were being actively treated. On the other hand, a similar period, so if you look at the EPICURE-2 data from 2006, which would have been about 5 years before the French data, looks at management. And if you look at management, say, again, at 22 weeks, so a proportion of babies being actively treated, but I would say that the majority having comfort care. And if you look at this blue figure over here, what you can see is a significant proportion of babies dying in delivery room, some stillbirths before labor and stillbirths during labor. So a very small number of babies who were actively treated at 22 weeks. But compared to France, if we look at babies resuscitated at 23 and 24 weeks, we obviously have higher numbers. So babies actively treated, obviously coming to about, I would say, 283. That's a good number of babies out of 339 at 23 weeks, with a survival that actually is double the rate in France. Now, that just shows that there is differences in practice where at similar time periods, active treatment at 23 weeks was actually followed in the UK, whereas in France, for a period further ahead, they were less likely to actively resuscitate even babies at 23 weeks. Now, if we compare that with the data from Sweden, and this is the Express study that was done in Sweden, which is over a similar time period, what you can see is that if you look at actively treated babies at 22 weeks, they were actively treating up to 50% of their babies born at 22 weeks at that time. Not unexpectedly, the survival was higher, but they had a more active approach to trying to treat these babies. And clearly that translated into a more active approach at higher gestations, including 23 and 24 weeks, which translated into higher survival. I think the big question from our perspective is, does increased survival actually translate into better neurodevelopmental outcomes? I think the question that I'm going to bring up is that the clearly differences in culture in different countries, which then mean that from our perspective, we adopt slightly different strategies in how we counsel parents that might actually impact the way we then treat and resuscitate their babies. And I think a key aspect that I would like to kind of talk about, having given that introduction, is what the role of religion and culture might be in the decision-making process. So as a group, having given you a little bit of the background, I'm just keen to hear from my live participants at the moment. Do you think religion should play a role, or that culture should play a role? Because at the end of the day, it's the child's best interests that's at the heart of all our decisions. I mean, why should religion and culture make a difference? I mean, we should be making decisions in the best interests of the child. We should be doing what's right for the baby. So I'm just curious, and I'm going to put Leva on the spot. Leva, what do you think about that?
I find that quite a difficult question, and I've been thinking about things like that before this lesson teaching session. It's something I've been thinking about quite a lot, and I don't know. It shouldn't have an influence, but I know it does, because maybe, and it probably also has an impact on the decisions we make as medical professionals, but in parents' decisions, it definitely has a huge impact. And we should respect that, but it can make it difficult sometimes.
Okay, that's a fair point. Charlie, any views?
Yes, I was just thinking about this, and actually in the last sort of 15 minutes, my pace has changed slightly, which is odd. Anyway, it's dawned on me that we can't judge what the child's best interests are, or isolated from religion and culture. Any one of us making our decision about what we think that child's best interests are using our own life experience, learning, religion and culture to make that decision. So it probably does need to be involved in the decision making if it is inherently involved in the identification of what the child's best interests are.
Fair point. We've got Robin with us. Robin's a consultant from Leicester. Robin, what do you think?
Hi there. I think it's very difficult, isn't it, when you've got conditions where, you know, survival is, you know, you can sort of say there's survival that's better in different countries, but actually survival overall is not that high. And, you know, there is a lot of morbidity attached. And I think we work in a framework, you know, set up by society, and that depends on sort of religion and culture. And so it's very difficult to separate that decision making, I think, from that framework. And so it is difficult to say, you know, we all have, I suppose, religion in some form or culture as part of our decision making. So yeah, it's really difficult. I think it really, you know, it does have an impact.
So I think a common message and theme that I'm hearing is that, you know, while the child's best interests are kind of at the heart of all our decisions, it's clear that how we interact with parents, their background, culture, their values play a huge role when we're trying to communicate these decisions to them. Now, I'm just going to give you a flavor of my experience of kind of having counseled parents in different countries, in different societies, I would say at different stratas of socioeconomic status, not just in the UK, but in India and in the UAE. And, you know, I've come across a lot of different kind of themes. So just looking at those themes, I think the one thing that I wanted to kind of look at is, well, what are the parents' perceptions and what are the doctors' perceptions with regards to culture and value in families? And one of the things that I've encountered when I counsel parents in India in particular, and, you know, is that doctors, to an extent, you know, in hospitals are sometimes viewed as people who should be, they're like gods. They are the decision makers. They are the sole authority. They, you know, theoretically, when I'm speaking to parents about life and death decisions with regards to their children, if I start going back to them and asking them, well, you've got a baby who's 23 weeks of gestation, would you like me to resuscitate the baby? They would kind of think that's crazy. I think the reason they would think that's crazy is because they kind of wonder, well, is this doctor competent? Why is he asking me this question culturally? Because actually in my society, I would expect a good, competent doctor who has good knowledge to be making those decisions and actually telling me what he wants to do. They're kind of understanding that actually what I'm trying to do here is involve them in that process, shared care decision making, trying to get them to understand the implications of having a preterm baby, the potential problems they might have, might be overridden significantly by the fact that actually it's the doctor who always advises what's right. And actually, they might actually think that actually something's wrong here. This doctor is not a good doctor. Let's go to the next one. But at the same time, having worked in and seen and counseled parents in the UK antenatally, you know, we often speak to parents at 23 weeks and say, for example, now 22 weeks of gestation, where we're giving them a kind of a picture, which obviously we're talking about their baby all, but then trying to contextualize all the problems this baby might have if it survives, trying to contextualize whether this baby will survive, and then kind of asking them what they want us to do, because actually there's a choice to be made here. And a significant amount of parents would find that a burden, that decision. They would have a huge amount of guilt in making it. You know, it's kind of, am I being asked to say that you shouldn't resuscitate my baby? Am I being asked to say that actually I should let my baby die? You know, that frame at this particular point is a major issue. And the question is, how do we make that judgment? And is it fair for us to then put that burden on the parents? So I'm just keen again to throw that out there. And I'm just keen to get views. I wonder what we think. So I'm going to start with Charu. Charu, what do you think?
I think it varies enormously from family to family.
Yeah.
I absolutely get the burden of guilt thing, but I'm always so interested in how, and I've only ever practiced in the UK, in how we have this concept of parents getting there. So rather than a very sort of specific moment of decision, we have the doctors and the nurses starting to mumble and grumble about, should we be resuscitating, should we be doing this? And the parents usually eventually coming round to our point of view. And I suppose it must be a slow drip conversation that we're having. But we don't specifically often have a moment when we go, right, are we resuscitating or not, in a very hard line? Which I guess is us trying to softly get the parents to make a decision with us without putting that sense of guilt on them.
I think that's beautiful, Charlie. It's kind of the way I look at that is we're shepherding them and we're trying to get them on board. Does that sound okay?
Absolutely. Yeah.
Yeah.
Absolutely.
Fantastic. Gautam, you practice in India. I'm just curious. I mean, what do you feel about this? So when you counsel parents, say, for example, for the stations, and you're doing babies at 24, 25 weeks, I mean, is this more about telling them what they should be doing?
Yes, yeah. I mean, it's very difficult because here, as you had said, that we are expected to make all the decisions for them, because they might not be aware of the implications of a preterm child. So we really try to inform them everything in detail, but some of them are not in a position or not in a frame of mind to make that decision themselves. So they expect us to make the decision for them, and so in that process, we ultimately decide the plan of management for the baby, and we try to convince them that this is the like we need to be making this plan in this way. So ultimately the entire burden falls in our hands. So but then we usually try to inform them of every possible complications that happen in a preterm baby. So this is this is the kind of situation that we face here in India.
So Gautam, I'm going to put you on the spot. Can I ask, how much does the parents' ability to pay and manage and support themselves monetarily, how much does that affect your decision making? Because obviously, I'm just curious.
I understand. It does affect a lot because in a government setup where the treatment is free of cost or it is at a subsidized rate, they are able to manage for ventilators or surfactant or any other life-saving drugs that may be needed. But in a private hospital or in a private medical center where the surfactant itself is very expensive and the ventilator charges and the bed charges per day amount to a lot. So we have situations in which the decision to not to resuscitate is mainly because of financial reasons. It might not be because that they may not be able to take care of the child later on, but the immediate financial implication is so huge that the entire burden falls on them. They have to make arrangements for the huge amount of money immediately. They might have to ask about their relatives, or they might have to sell few of their personal belongings to make sure that the child receives the care that is needed to make sure that the child crosses the initial critical period. So it does affect their decision a lot. And at that time, we might try to get them a certain subsidized rates by talking to the medical superintendent, but ultimately it does affect the decision that the family takes.
So Gautam, how would you approach that culturally? I mean, if a parent can't pay for it and you're not going to resuscitate the baby, how are you going to culturally communicate that in your setup?
So since I work in a private medical college, we try to with the limited amount of time that we have antenatally, we try to explain them about the possible implications of the cost and as well as the hospital stay once the baby is born. We try to we have certain insurance process that helps to take care of the baby. But when there are situations in which the family is not able to pay, we try to refer to them. We try to refer them to a center where the rates are subsidized, or where they do not have to spend so much of money to take care. So it would be a central government or a state government institution.
Sure, that's really helpful. I think coming back to my slide, I'm going to give you the other side of the coin and kind of say that there are cultures and countries where parents feel that they should be the sole arbiters of decision making, and that the autonomy involved in their ability to make those decisions is a basic human right which should not be taken away from them. That actually it's their sacrosanct right to make decisions when it comes to making decisions about their children. And a very good example and that I would give you is working in the UAE or Saudi Arabia, say, for example, where I think, taking religion aside, you cannot necessarily go against the parents' wishes if that is what they want. And if they want resuscitation of a baby who is extremely unlikely to survive or have very severe outcomes, it becomes very difficult in those circumstances to then say or try and go against those wishes. So legally, if you're in that situation, what you have to do is get a fatwa where at least two other consultants have agreed that that is the right thing. And if the parents still disagree, it's very difficult to then go against their wishes. Inevitably, those babies will end up getting resuscitated. The last aspect that I wanted to cover is the fact that, there are situations where parents will want to protect their child's right to life and life at all costs. And again, if you go to the States, say, for example, there are certain states which have statutes which kind of say that it's illegal to have an abortion under 20 weeks. You have to have a pediatrician present for all babies who are delivered after 19 weeks of age. And actually, the expectation is that those babies be assessed. We can't resuscitate them, or at least I know that my colleagues in the States can't resuscitate them. But some of those babies might actually be bigger or have a better gestation, more maturity. And some parents would argue that they have a right to life. And culturally for them, religion might play a huge role over here. But if I just look at decision-making models, taking those different cultures and countries into account, what we look at is a model of medical paternalism, where, say, for example, we agree that we as the doctors and the medical team and the nurses are the people who should be making those decisions, where technically we are the arbiters, the sole authority who makes decisions in the child's best interests, versus some countries where there's complete parental autonomy. And if I give you an example, I've talked about Saudi Arabia and the UAE, whereas without saying, I think it'd be controversial for me to say, whether there's a particular setup, but there are certain setups where doctors would make and inform the family about how they are going to resuscitate the baby. And then there's a shared care approach. And the shared care approach basically talks about decision making, where we're speaking to the parents, we're giving them information in a considered, honest way. We're trying to risk assess and stratify what the risk of survival for this baby might be, what the neurodevelopmental outcomes might be. But what we're doing is we're taking the culture and value of the parents into account. We're taking their circumstances into account. We're kind of trying to hone in, establish what we think would be a decision for the baby in its best interest. But the question then is, can we shepherd those parents based on their culture and their values into a decision that we think is good for the baby? Now, that is what I would call is beneficial paternalism, because actually, at the end of the day, we're still trying to get them on board with our medical decision making. On the other hand, there is complete shared care, which I've marked here in green, which kind of talks about an approach which means that we have an uncertainty about the outcome for this baby. We're not certain that this baby will die. And actually, we're uncertain about the prognosis. And we're in a situation where we would do exactly the same. We would talk to the parents, be honest about what we can be honest about. We may or may not come to some recommendations. But at the end of the day, rather than us making that decision, the parents have a zone of parental discretion in which they would then make the decision. And almost certainly, I think, in societies which encourage this, if the parents then wanted resuscitation, the medical professionals would support that. And very nice example of that is the Swiss perinatal guidance. And I would circulate that to you, which basically talks about zonal parental discretion, as does the most recent guidance that's been published in Australia by Rosemary Boland and her group, where between 22 and 23 weeks of gestation, they have given the parents the discretion of whether or not to resuscitate the baby, but clearly talking about the high risk at 22 weeks and advising that perinatal palliative care for some babies at 22 weeks should be the norm. And a good example is for babies born in level 2 centers in Australia, outside of, say, Melbourne, bringing those babies to a level 3 center almost always results in a very, very poor outcome. So actually, one of the recommendations is if you have a baby at 22 plus certain gestation, and if they're outborn or born in a level 2 or level 1 center, actually palliative care is recommended as opposed to resuscitating that baby and transferring, unless an in utero transfer is possible. So what you can see is we've adopted different models based on the cultures prevailing in that country. The question from my perspective then is, where does religion come into this? So I'm going to talk a little bit about slight differences in different religions. I'm not going to go through all of them, but I'm going to give you a little bit of a feel of, say, Hinduism. And I'm a Hindu. And, you know, if I was counseling parents, say, for example, who had a background of coming from India, I think if I was in India and I was practicing in India, I think their circumstances, their values would come into account. But there's absolutely no doubt in my mind that as a Hindu, if I recommended a certain way based on an honest approach of the risk of that baby not being able to make it or the high risk of a neurodevelopmental outcome, and that was inclusive of the parents' monetary circumstances. So if this is a family who's going to sell all of its land and can't feed itself for a baby at 23 or 24 weeks of gestation, I really worry about the suffering that baby will go through in those circumstances, the burden of medical intensive care to get a baby who might not have the facilities to be able to allow postnatal development care with a family who is at high risk of not even being able to feed itself. So I think if I were to then say that resuscitation for this baby would not be in the best interests of the baby, the family would probably agree with me. I wonder what you think. So I'm gonna stop and ask. So I can see that Charu is there. So I'm gonna ask you again, Gautam. What do you think? You're from India.
Yeah. So I would say that I would say that I would agree with you because financially, if they're not able to support the baby initially, as well as where there are few centers for the child to grow and develop, I would say my resuscitation, this thing would change. I mean, if they do not want to resuscitate the child at that time, then I would probably, try to convince them. But if at all, if it is not possible, then I would have to go ahead and agree with the parents, because this is the circumstance that is here. Maybe if I was in a different center, maybe then I would do otherwise. But based on the family's financial status and their ability to take care of the child later on, would probably affect my decision at the initial resuscitation process itself.
So if you look at Hinduism per se, the quality of life and the kind of life you're going to lead takes a huge precedence in our religion. I think it's really important that from our perspective, a life is going to be fulfilling. There's going to be a good quality to it. And I think that's quite crucial. And clearly circumstances outside of survival and neurodevelopment are very important from a religious perspective. I'm just curious, Charlie, what do you think about other religions? Have you any experiences?
So I'm a Roman Catholic myself. Apologies in advance, there's some building work going on outside my house and they're cutting stones. So if they do it again, I'll mute because it'll be impossible for anyone to hear anything. Can you hear me?
Yes, yeah.
That's fine then. So I find the balance of religion and my religion, other people's religions, other people's lack of religions, their culture and things, something that's a very fine line to tread. If I were to strictly follow the teachings of the Catholic Church in terms of resuscitation, it's a little bit more nuanced than many people think it is, in that the Catholic Church does hold life sacrosanct, but that's not to encourage suffering as such. But I would probably err more on the side, if I were following my religion specifically, or supporting another Catholic, follow more on the side of resuscitation, and indeed later on in neonatal care, sort of keeping going, as it were.
Yeah.
But my practical and emotional experience of neonatal care would very much often lead to suggesting a path of not resuscitating or redirecting care to a palliative approach. And knowing that I have that conflict in me, and I'm the professional, not the parent, I can see how religious instructions, religious beliefs that people have may make it really hard for them to make those decisions, even when we are supporting them. And one of the things I've often spoken to families about, if they've mentioned that they are struggling to balance their religion, their personal beliefs, what they can see their baby suffering through, is to always go back to the focus of, and I think almost all religions actually at the centre do hold this to be true, that God is a loving God. Whatever you call him or her or them, it's a loving concept. And we have to live within that. But I think it's a very complex topic.
Yep. I think that's beautiful. I mean, like you said, kindness, love, I think really important aspects of values that we bring with us. Robin, can I pick your brains?
Sure.
So, Robin, do you have any religious views?
Similar to Charlie, my background is as a Roman Catholic, and I agree with the idea that what she's put forward, that life is sacrosanct, but it's more nuanced on that. And I follow the same sort of roots, really, your sort of practical knowledge, and perhaps putting to the forefront that God is meant to be a loving God, that idea. And what you mentioned about Hinduism, about sort of having a good quality of life, does come to the forefront, and so that would generally be our approach. But it is true to say, when from the time that you've worked in Leicester, you know that there are some groups. We've got a mix. We've got say people who don't declare religion, but we've got Christians, Hindus, and Muslims, and many of the Muslim families will have more difficulties, perhaps, with decision making around wanting to keep going rather than perhaps sort of comfort care.
Yep. Completely agree. And I think, the challenge from our perspective in those circumstances is, how do we approach that, the potential for disagreement, the potential for, trying to get the parents on board, which might take time, which then means the baby might suffer during that period. And I agree, it's really complex. And I think what we're going to do is, we're going to talk about a case where I'm going to try and see how we might approach that. Before that, I am going to say that, like Robin has said, for parents who have, say, a Muslim background, again, I would say that the consummation means that if a mother has had or is pregnant for 40 days, so after 40 days, religiously, they don't consider viability to have taken place. But after 40 days, for them, viability has been achieved. And even at low gestations, I mean, with the recent guidance that's come out, a lot of parents would want resuscitation of extremely preterm babies in countries in the Middle East. And clearly, we have available medical technology that can only resuscitate babies at a certain gestation and weight. but with babies who might have very high risks. And it then becomes quite difficult for those parents, based on their religious views, to be able to say that actually I should let my baby die, because in their sense, as defined by their religion, their baby is viable. And the question from our perspective is how we manage that situation. And the strategies that we've got in the UK, so I can speak for strategies over here, but I'd be really keen to learn from all of you. So with that in mind, I'm going to give you a little bit of a case. So we've been asked to counsel a mother, and I'm going to get Lever to start, but just giving you a little bit of a feel of the situation, Lever. So a baby who is in utero at 23 weeks, the mother basically has got and had rupture of membranes in 16 weeks with anhydramnios. The main problem is she's now come in and has intermittent APH. A scan done, so an early dating scan showed this baby has severe bilateral congenital diaphragmatic hernias with very severe lung hypoplasia. I mean, there's virtually no lung visible. The baby's estimated weight is 400 grams. Now, the parents are of faith, and you've been asked to counsel them. You have spoken about things, and I've got the kind of BAPM guidance up here, but I'm just curious, Lever, what do you think? Should we, do you think this baby, the parents are keen for this baby to be resuscitated based on their faith?
Okay. Well, if the parents are very keen for this baby to be resuscitated, we need to take that into account. I don't necessarily, I'm going to say that's the only decision or discussion I would have. I would definitely discuss this with my medical colleagues, my medical team, because this baby's got a lot of risk factors. I mean, it's a 23-weeker. It's not that it's just going to be 40% survival, because obviously there is severe lung hypoplasia, bilateral congenital diaphragmatic hernia, and a weight of only 400 grams. So this baby has, in my opinion, more chances of dying than of surviving, even with resuscitation. So I would try to have a very good discussion with these parents and to come to some decision that they can also agree with. But and I do think, as Charlie and Robin said, in people with Catholic faith, which is also my personal faith, I do think you could kind of try to explain that. I mean, we are in favor of surviving and to encourage life, but it's not the aim to go through a lot of suffering as well. While I've also worked with a lot of people with Muslim faith, mainly in Belgium, they will just want that this, even if you come up with this advice that the baby has got a lot of chances of dying, even with resuscitation, they will want you to go for it, especially if they're very strict to the Muslim faith, because they will actually literally say in Belgium to you, Allah will decide. And if the baby then dies, but you've done resuscitation, they will agree with it as well. So it's not that it's impossible to come to something, but like, while with people with Catholic faith, I do think you could come to an agreement to go for comfort care, even from birth, while with most strict Muslim people, and that's not, there's no right or wrong, they will more likely want you to at least try resuscitating. And then if they've seen it works, it does not work, sorry, then Allah has decided, and then they will also they will also agree with it.
That's fantastic. Thank you. I mean, I put you in the spot and it's quite complex. I'm just curious, I mean, from a straw poll, how many people think comfort care is the right option? I mean, intubating, risk of pneumothoraces, drains, a lot of potentially painful, destructive procedures in the delivery room with a very high risk of not surviving. So if I give you an idea, I mean, 40% based on gestation, but looking up the literature and having seen this, I mean, this baby, I give a less than 5% chance of surviving. I mean, developmental outcomes likely to be horrendous, but the key question from my perspective is the pain and suffering that we might put this baby through if we resuscitate this baby. That's just my anxiety, and it's just one approach. But I'm just curious to kind of get an idea from my other colleagues. What do you think, Robin? What do you think? Would you recommend palliative care at this stage to this family, or do you think there's an option to kind of give this baby a go and show the family that we've tried?
No, I mean, I think we would. I think somebody had already mentioned about discussing with colleagues. I think we would do that, and I don't think we would in any way offer any sort of active care given what's the details that you've put forward there.
That's really kind. Charlie, what's your feeling?
Most of my feeling is absolutely this child should not be offered any resuscitation. It looks like a hopeless scenario, and lots of love and cuddles need to be offered. But I think one of the things you said earlier, Alok, about pain and suffering of the baby do need to be considered in the context of the parents. Yes, we are all there looking after the baby, but we are looking after the baby as a centre of a family. And if the pain and suffering that the family are going to undergo because we've not appeared to try any resuscitation are so huge, there may be an argument for balancing those two and agreeing some level of resuscitation, even though we believe it's going to be futile and the child may suffer, to reduce the parent's suffering. I would hope that we could get to an agreement in this case that that wasn't the route to go down. But I do think we need to consider a bit the parents' pain and suffering as well. They have to live with it after all.
Can I just come in there, Alok, and say, actually, yes, I think that's as part of that. I mean, I'm not saying that I would necessarily resuscitate this baby, but certainly I think we feel it's really, really important to have somebody senior there at that delivery, so that the parents do feel that they've been supported.
So I've got Alice Kavati. So Alice.
Hi, I'm Alice. I'm a nurse practitioner. I'm also from Leicester. I think it's quite interesting when we're talking about religion, because I suppose it does depend on how observant an individual is, and as a and what I have a certain understanding of Islam. It is all encompassing, and certain types of decision making and parents being placed in situations like that. It could prove to, well, it would, as with all parents, prove to be very challenging. I wondered about the use of maybe some religious leaders, to help sort of facilitate decision making in that context. I suppose it depends on the situation of, if the woman's labouring and so forth, to help with any difficulties that may occur with communication. Again, this baby faces a number of challenges, and to undergo resuscitation would, from my perspective, would likely be futile, and the baby would endure a certain amount of suffering, and that's hard as a health professional. And I think the thing is, we talk a lot about decision making from the perspective of the parents, which is a great burden for them. I could appreciate, but also we need them too. I think when we're making difficult decisions about reorientation of care and resuscitation at the very sort of margins of viability. Yeah.
That's beautiful, Alice. So I'm going to put you on the spot and say that you have counseled them. You went back to your team. We've had a multidisciplinary discussion. So clinicians, obstetricians, we've sat down in a room, and I think we all agree that comfort care is the best option for this baby at this particular point, which will give the parents and the family good time with the baby. Gone back to the parents want everything done for the baby, as religion would not allow them to let the baby die. So how do we think we're going to approach that?
I guess the question would be, what is everything? Because I know I've recently had a conversation with the parents about baby that we had to resuscitate in their absence, and they said, "Did you do everything?" And we had, well, we'd done a lot, but we hadn't defibbed, we hadn't used drugs, we actually hadn't had to use chest compressions. So it was unpicking with them what everything meant. And as they said that, and we had that conversation, I thought about future conversations with families in this sort of situation when they say we want everything done. What is everything? What do they mean?
Yeah. Anything else? Anybody want to mention anything else? So there's a concept that I have kind of used in my practice. And basically that concept talks about understanding what the parents mean. And that's crucial, because even though they might have a religious connotation to it, we might be in a situation where actually that religious statement actually pans out to mean a lot of different things. And a good example is, I've recently been involved with a family of a certain faith who gave me this exact answer. They said that religion would not allow them to allow their baby to die. But actually, when we explored that a little bit further, what they meant by that was that actually, if the doctors were of the opinion that the baby's best care was comfort care, then actually they would accept that as long as it was the doctors making the decision and it did not have to be them making the decision, because actually religion would allow that. So clearly, from our perspective, there are lots of connotations to what that might mean, and it's very important that we explore the concept of what I call as the frame. The frame basically means that, well, religion is a significant factor in their decision-making process, but actually, what is it about the religion per se that means that they want us, or they're making a particular decision? And is there a possibility that I can use means, or I can get them to be able to understand either that there is a ceiling of care, and that means that we don't stop caring, and that actually comfort care is not stopping care. It is actually caring. We are caring for him. He is going to be warm. He's going to be with mom. We're going to continue to do that. And actually, once he passes away, that's actually him making his decision. So that is one way of approaching it. The other way is speaking to a local leader, like we've just said, or an imam, or say, for example, a Hindu priest, or as we call, a Sikh guru, who might be able to come down and actually speak to the parents, translate, and actually reassure the parents that actually, because there are, Islam did, or say, for example, Hinduism or Sikhism, it doesn't actually say that we can't stop intensive care. I think that's where what we need to do is be able to frame in a way that the parents understand that it might be perfectly acceptable to do that. Now, this approach, is a shared care decision-making approach. And it might be that we opt to go for comfort care and there's disagreement. But I think what we're trying to do is then make a judgment of best interests. We disagree, second opinion. This is kind of an approach for how we would approach disagreement. But if religion is in the background, I think you've got to take a step back and you've got to understand the context in which they are making that decision. And these are just some of the things that I've come across in situations like that. Clearly, we've already talked about the right to life and sanctity of life. Now, clearly, there is that, but the question is, if we get the parents to understand suffering, quality of life, that might also be very relevant. And that's something that then might, from their perspective, take a higher precedence than what they feel with regards to sanctity of life. Similarly, I've had experiences with parents who believe a miracle is going to happen. And actually my 21-weeker is going to survive. And, in that particular situation, the question then is how we are able to bring about the conversation that actually we don't have the medical technology to do that. We don't have the medical technology to do that. But more importantly, there is going to be an immense amount of suffering and destructive interventions that are going to happen, which is going to take away time that they can spend with the parents. And that might be acceptable to that family because their values of not letting their baby suffer and quality of life take precedence over their faith. And that is where I would say it's very important for us to sit down and understand that. With regards to religious scriptures, I mean, like you've said, getting the local imam, somebody who might be able to reassure the parents. The one thing that I do want to raise, and there is in some religions in particular, a huge worry that if parents talk about not initiating resuscitation or letting their baby die, that they will be ostracized by their community, that there will be other members of their community who feel otherwise from a religious perspective. And actually, by making that decision, they're not following community guidance. And again, having been in this situation, the one thing that sometimes helps in that situation is actually speaking to the community as a whole to kind of get them to reflect on the futility of the situation, the suffering and the pain, and reassuring them that actually, leaders might come forth and say, look, we understand where you're coming from. We're in a situation like this, and we will not ostracize you. We want to give you the comfort to say we will support you. On the other hand, sometimes you might be in a situation where leaders choose not to do that. And that is a very, very difficult situation to be in. So it can go the other way. I'm just curious from the group, just to kind of get an idea, have you encountered any other kind of disagreements or kind of frames that you've been able to explore from a religious perspective? Any other experiences? Okay, so I'm going to put Robin on the spot. Robin, if you had a family who you spoke to who were worried about being ostracized for the fact that they might let their baby die or talk about not resuscitating their baby, how do you think you'd approach that in Leicester?
Well, I think you've already alluded to a little bit by talking about speaking with the community, and we do. You have the religious leaders who would be available. If they have an imam, for instance, if it's a Muslim family, an imam who would want to speak to the family, and I think they can often be reassuring to the family about those sort of issues and acceptance by the community of these difficult decisions.
Yeah. Has anybody been in the kind of context of a faith and a miracle is going to make my baby survive kind of situation? I'm just curious to explore that.
Well, I suppose in certain religions you might pray to certain saints for, special intentions. And when you're going through very difficult times, you will. There are pilgrimages that you can undertake, and you can say, for example, if you lose something, you can pray to St. Anthony. It depends on what you've been brought up with. I think one of the things I was thinking about, so I worked in New Zealand, we're looking at religion and culture separately, but I think sometimes religion is, or interpretation of religion is shaped by cultural differences. And even if we look at Islam, there are different sectors, different, so there are different types of Islam that is followed by different, people, say Shia or Sufism and Sunni Wahhabism, and actually how. So you can be quite surprised, and it depends on your own understanding of what you're used to, what your own, so I suppose, for want of a better word, your own lived experience of that particular religion is. Going back to New Zealand, and my experience of working with the indigenous Maori population and also Polynesian populations there, it's about, I suppose, individuation and how, some communities, some cultures, they don't see themselves as an individual so much as part of a family group, and any decision making would be made as part of a family conference and discussion with elders. The elderly people have, very special and very much valued sort of life experience. And certainly in New Zealand, when we were looking after, babies, and again, where there was, we were discussing reorientation of care or resuscitating babies, 24, 25 weeks. Back then it was a wee while ago that I worked in New Zealand, but there would be discussions, you know, with the whole family, with the whole whānau, and that was really important, really important that any decisions were made that were discussed with the family rather than just as individual parents. Yeah.
I have an interesting experience of faith, and I mean, just a baby who we had with born at 23 weeks. Eventually, discussions with the parents after having had, nearly a third course of DART in a situation where we were looking at end-stage chronic lung disease, and I mean, clearly from our perspective, having gone through the multidisciplinary approach, a second opinion, an ethics panel, the kind of next stage was actually approaching courts. And the difficulty for us at that particular point was the family's very firm belief that the baby was going to make it and this was going to be a miracle. And one of the ways we were able to get the parents on board with the fact that actually it was a miracle that a baby had survived 23 weeks with the severity of the other risk factors and problems that the baby had, but that actually extubation had failed. And on each time, the miracle had not taken place enough to be able to get the baby to survive. And actually, by having those discussions, we were in a situation where we were finally able to get the parents on board. I think the challenge for us is, and with people looking after the baby, is that was putting the baby through a lot of suffering. And one of the things that I went back with, well, did I do the baby harm by actually going through those cycles of extubation to demonstrate to the parents? And should I have gone to court earlier? And I'm just curious. I'm going to put it out there and put myself on the spot and say that, if a baby is suffering, is it fair to let them go through that to demonstrate that a miracle is not happening? And is that the right thing? Charlie, what do you think?
I think, so the answer to the question, if a baby is suffering, take that bit. I think no, but we have a lot of ways of making sure the baby isn't suffering. We can medicate around that. In terms of, were you right to do several extubations? Probably yes, because as I said before, the family have got to live with this forever. And we can't just, without going to court, without going to higher authorities, we can't just stop against the parents' wishes. And so I think it always has to be a balance. But the baby suffering, as you say, does have to be very much considered. And I suspect, I think this case was before I worked with you, if it was even in Southampton. But I suspect you had a lot of pressure from the nurses around this baby suffering. What are we doing? What are we doing? What are we doing? And so the important thing in that circumstance is to make sure that the baby isn't suffering while we go through the process of bringing the parents along.
And again, ethically for me, it was so difficult because if I have to give the baby a fair chance, I have to wean the morphine. And the problem is that the baby does need to be on morphine. It was a big baby on the ventilator. So I completely acknowledge it was extremely difficult to try and make sure that you're meeting the needs of everybody. But yeah, pain relief was a very important aspect in that situation. Keeping the baby comfortable while he was intubated was absolutely crucial. And, we tried to optimize that as much as possible. Robin, any views?
Yeah, I was just going to, well, I agree with what Charlie said. The other thing is given that that's what you actually ended up doing, which sounded completely appropriate, did you get feedback from the family afterwards? Because I think in this case, is if you'd gone to court, they may have suffered long term about the decision making, but the way that they were able to see that the baby really wasn't going to survive will have helped them in the long term. But did you get any feedback from the parents?
Yep. I mean, I'll be really honest to say, for confidentiality, it'll be difficult for me to go into explicit detail, but I think my perception and the feedback from follow-up was that they felt relieved that they had given their baby the best possible chance under the circumstances. And, in their minds, the one thing that they communicated back to me was that they felt that the baby, having made it and gone through that duration, was a miracle in itself. And, in a way, that time that they got with the baby was quite crucial and quite precious. So, in a way, I felt it was something that I could let the parents do, that I could get them on board with. And I completely acknowledge with Charlie's kind of view that my slight worry is that if I make that decision in isolation, I go to court, or I take that decision out of their hands, I'm disempowering them. They're going to have to live with this for the rest of their lives. I think a lot of multidisciplinary discussion, we did go up to our ethics panel over here, and there was a lot of discussion around how we should address this, but actually before that, we were able to get the family on board. Anybody want to share any other examples before I finish? So I'm going to talk about a little bit of a framework before I finish, to kind of say that if we have disagreement on religious grounds, the question from our perspective is how we might approach it. Now, clearly, decision-making about not initiating resuscitation at limits of viability, or for a baby who is born on the neonatal unit and has a condition which warrants us moving down the perinatal palliative care pathway, needs to kind of involve shared care decision-making. At least that's the process that we would follow in the UK. It means that you have an honest discussion with the parents about not just survival and neurodisability and the problems the baby is going to face, but actually suffering for me is very important. Quality of life I find really difficult because I can't predict quality of life accurately. I can't be certain about it. But what is the quality of life for a child who is 2 in a wheelchair, but actually, from my perspective, has developmental delay and actually can taste, sense, see, and communicate effectively, versus a 5-year-old who can do exactly the same? And my worry is that quality of life changes as the child grows, and quality of life changes for the family as they adapt to the child's needs. But certainly, I think pain, suffering for me is something very objective that can be demonstrated. But if obviously the parents then refuse or want to take a different approach based on their religious grounds, for me, what is really important is to really understand what they mean. And a key aspect of that is when we talk about they want everything, well, everything might mean that they want to see their baby alive. They'd like us to try, but actually that if we've tried and the baby's not responding to our efforts, that actually there's an approach here which means we can actually then move towards comfort care. And I shouldn't just take everything in the literal sense of saying that I've got to do everything. But the other aspect is there's some aspect of the decision making that we can help them with. Can we get somebody from their religious background? One thing that's really helped me is sometimes for families who have a religious background, but their first language is in English, is to be able to get a translator, somebody who's culturally close to them and can actually communicate in their language. Obviously, preferably not a relative, but what I'd say is our trust has guidance around who we should use and how we should use that. But somebody who can communicate in a very empathetic way with them and make our informed choice, I would say, more understood by them, taking into account their religion and values. It might also mean that, from my perspective, I might have a colleague who can actually speak the language and I can't. It might be that actually that person is better at this particular point in being able to have that conversation. And if I can use his skills, it might be that he's a better person than me actually in that situation to be offering or doing antenatal counseling. Clearly, for babies where we continue to disagree, as discussed, an element of further discussions, even with religious disagreement in the background, because it might be that religion doesn't allow parents to actually allow their baby to die. Well, the question is, would they allow you to make that decision? And would that be compatible with their religious faith and background? Would that be something that fits in with their culture and values? But if all of those things failed, then the question is whether we can look at demonstrating pain and suffering, methods like mediation, demonstrating fidelity, or demonstrating the benefits of actually, I would say we never stop caring. I think the key question is, can we get them to understand that actually this is caring for the child because the child is suffering? And those values might actually outweigh their religious beliefs. Failing that, obviously, we have pathways, and that often from our perspective would mean escalating to a second opinion, further to multidisciplinary discussions, another trust maybe giving an opinion on this situation. And I think legal recourse remains one of the final approaches. So to give you just one last view of, so when you approach courts and there's religious disagreement, who do you think the court favors? Anybody?
Would it be the child, the best interests of the child?
Okay, so best interests of the child. So I can say to you that legally, up till the last case for the parents from Bangladesh, whenever a case from a pediatric or a neonatal perspective has gone to court on religious grounds, the best interests of the child are paramount, but it's always gone in favor of healthcare professionals. But the last case doesn't set a precedent, looked at suffering of the child. So a child who obviously had a significant intracranial bleed, and actually came to the conclusion that the suffering was not of a severe enough nature to warrant that we don't follow the parent's opinion in that particular circumstance. So while I'd say that for the majority of cases, the decision is always made in favor of health professionals, taking the best interests of the child into account, clearly there's been a slight change. I'm going to end there. I think I'm going to summarize by saying that what is very important from our perspective when we have, and we're counseling parents, especially with different beliefs and backgrounds, is that we are trying to take into account their cultural values. We're trying to get them to understand exactly in an honest and transparent way what we think the problems might be, and that if there is an issue on culture, values, or religion that they feel they would like to make a different decision with regards to, we should explore the frame. We should try and understand actually what that means. And in my experience, I mean, in the majority of cases, I think you're almost always able to get parents on board. At least I have in the last 12 years that I have been here. But again, Robin is obviously much more experienced than me. Robin, have you had any cases gone to court on this?
Yeah, I mean, I think one of the things I was going to make a comment on about cases going to court were about that there can be different healthcare professionals involved and that they can have different opinions, and that confuses the whole situation.
Yeah. So that's fantastic. Any other questions, guys? Anything anybody would like to ask any of the other participants? I mean, I've learned a huge amount from everybody today. I'm just keen if you want to ask any other questions of any of the other people. That's fantastic. I'd like to thank you all for attending. I'm really grateful. Once Victoria is well and I get a date from her, I will recirculate it to all of you. Thank you so much.
Thanks,
Thank
Alok.
you.
Thank you.